Memorizing the large volume of medical material is absolutely difficult. In this collection, an attempt has been made to present the content in the form of multiple choice questions in order to create both real space and increase the power to memorize them. Today, the topic I want to talk to you about is approach to anemia. In this section, I'll define the anemia and give a general overview on this subject. Question 1. A 35-year-old man presents with weakness and lethargy. In performed test, hemoglobin is 8.5, MCV is 60. In complementary test, serum iron is 20 and TIBC is 430. What is the most likely cause of anemia in this patient? 1. Iron deficiency, 2. Folate deficiency, 3. Chronic renal disease, and 4. thalassemia. Anemia is defined as reduced absolute circulating red blood cells. In the laboratory test sheet, what's representing this finding is the level of hemoglobin. So a reduced hemoglobin or a reduced hematocrit level represents the anemia. The cutoff point for this definition in women is less than 12 gram per deciliter, and in men is less than 14 gram per deciliter. You know, there are many functions related to red blood cells. The most dominant type, the most known, is carrying the oxygen and carbon dioxide in the body. This function is referred to hemoglobin component of red blood cells. So as you see here in this question, the patient presents with lethargy and weakness. So as said, looking at hemoglobin level is the first step for diagnosing anemia. For categorizing the anemia, there are many methods. A well-accepted method is based on the mean corpuscular volume or MCV measurement. MCV represents the average red blood cell volume. So according to MCV measurement, 3 status can be expected: normal, decreased, and increased MCV. In other words, microcytic, normocytic, and macrocytic. In microcytic anemia, the MCV level is less than 80 femtoliter. In normocytic, the MCV is between 80 and 100 femtoliter, and in macrocytic, the MCV is more than 100 femtoliter. Micro refers to small, macro refers to large, and cytic or cytic refers to something relating to the cell. So in this question, you see both hemoglobin and MCV are reduced, so we have a microcytic anemia. Here we continue the subject by focusing on microcytic anemia. In microcytic anemia, there is always a problem in making the hemoglobin. For better explanation of microcytic anemia, so we should know the hemoglobin structure. The structure of hemoglobin consists of 3 components. So, compatible with these 3 components, we also have 3 main causes for microcytic anemia. Hemoglobin includes heme and globin, and heme itself includes protoporphyrin and iron. Globin are protein structure, are a type of polypeptide made up of amino acids. Globin molecule in adults itself includes 2 types, alpha globin and beta globin. The protoporphyrin is a complex molecule that iron is located in the center of it. The oxygen binds to iron in the center of protoporphyrin. So according to hemoglobin structure, if we have problem in making globin, it refers to thalassemia. If the problem relates to making protoporphyrin, this type of anemia called sideroblastic anemia. And if it is related to iron shortage, it called iron deficiency anemia. However, we have a condition called anemia of chronic disease. In this condition, the iron level is not reduced, is adequate, but related to inflammatory status of the body, such as seen in rheumatoid arthritis. The red blood cells cannot use this iron to making the hemoglobin. We call this type the anemia of chronic disease. So in this case, Hemoglobin and MCV both are reduced. That presents microcytic anemia. So the options 1, 3, and 4 are possible. But the iron level make the iron deficiency as the diagnosis. So the correct answer is 1. Question 2. How many days is a lifetime of red blood cells RBC normally? 1. 30 days, 2. 60 days, 3. 90 days, 4. 120 days. Red blood cells or erythrocytes are widely known as cells carrying oxygen in the body. This function relates to hemoglobin component of red blood cells, but other functions and enzymes are also found in red blood cells. The origin of red blood cells refers to bone marrow. Actually, the progenitor cells, the myeloid progenitor cells in the bone marrow, called pronormoblast. Red blood cells produced in the bone marrow in a process called erythropoiesis. This process is underwent in a way that at first a premature cell called reticulocyte produced. This cell finally evolved into mature red blood cells. This process, like any other process in the body, needs protein, hormone, enzyme. The hormone here is erythropoietin that mainly secreted from kidney cells and to somewhat by liver. Actually, in kidney there are cells that are sensitive to amount of oxygen in the body. If they found the body demand for oxygen in relation to available oxygen is not adequate, induce the erythropoietin secretion. However, erythropoietin is not the sole hormone in this process. Other hormones play the role. For instance, thyroid hormone and androgens. Maybe the androgens are the suggestive cause for the more amount of red blood cells in men rather than women. After 3 days, reticulocytes enter the bloodstream and convert to no red blood cells. In a normal status, the absolute reticulocyte count is 50,000 in per microliter. The mature red blood cells circulate for about 120 days in the body and finally are removed by macrophages and monocytes in the spleen and liver, known as reticuloendothelial system. Actually, reticuloendothelial system remove either old or unfunctional red blood cells. So the correct answer is 4. Question 3. A 20-year-old woman referred to you because of hemoglobin of 8.5. In physical examination, the only finding is paleness. Laboratory tests show normal white blood cell, platelet, and red blood cell indices. What is the next step? 1. Calculating reticulocyte count. 2. Bone marrow biopsy. 3. Spleen and liver imaging study. And 4. Hemoglobin electrophoresis. So here the question presents an individual who is asymptomatic, anemic, and has normal MCV. What the question asks is, what do you recommend when the anemic patient has normal MCV? In this case, the next step is calculating the reticulocyte count. As said before, reticulocytes are premature red blood cells in the bone marrow. So, the correct answer is option 1. The reticulocyte count can be high or low. When it's high, it's indicative of the attempt of bone marrow to compensate the replenished blood. The two main causes here are hemolysis and hemorrhage. Low reticulocyte count represents bone marrow disorder, such as aplastic anemia. That means the bone marrow is not capable to produce sufficient red blood cell. However, in this case, usually other cells are also involved. Question 4. A person has been diagnosed with anemia. In the lab test, the absolute reticulocyte count is 120,000 per microliter. Which of the following statement about this patient is true? 1. Hematocrit count is required to correct the absolute reticulocyte count. 2. Hemolytic anemia is the most probable diagnosis. 3. A bone marrow study is necessary in this case. And 4. Evaluating renal function is required in this patient. As said before in the previous question, calculating reticulocyte count performed when the anemic patient presents with normal MCV. In other words, is normocytic anemia. However, when the hemoglobin is lower than, for example, 14 in men, it's anemia. So hemoglobin count of 13 is anemia, 10 is also anemia, and 7 is also anemia. Don't you think that the compensated reticulocyte count should be different in such conditions? The answer is obviously yes. So when we look at reticulocyte count as a number in percentage in the test paper, it's not sufficient for conclusion. We should calculate the reticulocyte production index as multiplying this reticulocyte count by the ratio of patient hemoglobin to normal standard hemoglobin. Another way is when the test presents itself the absolute reticulocyte count. In a normal individual, the reticulocyte count is 1% and the absolute reticulocyte count is up to 50,000. When the reticulocyte production index is more than 2% or absolute reticulocyte count is more than 100,000, hemolysis or hemorrhage are probable. So in this case, according to number of absolute reticulocyte count that is more than 100,000, the correct answer is option 2. That means hemolytic anemia is the most probable diagnosis. Question 5. In the laboratory examination of a patient, the following findings are obtained. Hemoglobin 7.5, MCV 84, femtoliter, MCHC 30, and reticulocyte count 3.5%. What is the most likely cause of anemia in this patient? 1. Iron deficiency anemia, 2. Hereditary spherocytosis, 3. Hemolytic uremic syndrome, and 4. Chronic kidney disease. I should say at first that this question is a little complicated, so what do you comprehend from this case? A low hemoglobin represents anemia. A normal MCV between 80 and 100. In the matter of MCHC, simply could be said that it represents the hemoglobin concentration. MCH, or mean corpuscular hemoglobin, shows that hemoglobin concentration in an individual RBC. MCHC, or mean corpuscular hemoglobin concentration, shows the average hemoglobin concentration in RBC population. These two parameters represent the hemoglobin concentration. When they are decreased, they are compatible with hypochromia, such as iron deficiency anemia or thalassemia. When the MCHC is increased, it is compatible with hereditary spherocytosis. Here is the normal RBC indices. According to a standard range in this case, an anemia with normal MCV and a normal MCHC presence. So you could see that the option 2, hereditary spherocytosis, is excluded because the MCHC of the patient in this case is within normal range. When you see the reticulocyte count of 3.5%, you may consider hemolytic uremic syndrome, as this number is more than 2%, indicating a type of hemolysis, but this is not true. You should first, as said before in the previous question, calculate the reticulocyte production index by multiplying this reticulocyte count by the ratio of patient hemoglobin to the normal hemoglobin. That results in 1.75, that is lower than 2. According to this discussion, we have a type of hypoproliferative anemia, such as iron deficiency or anemia of chronic disease. So the options 1 or 4 are the answer. So if it is iron deficiency anemia, when the hemoglobin count is less than 10, we expect that we have microcytosis and hypochromia. So the correct answer is for chronic kidney disease. that is compatible with anemia of chronic disease. We can conclude another keynote from this case that the MCV and MCHC in the anemia of chronic disease may be normal, such as seen in this case. Question 6. A 25-year-old woman has been referred to you due to anemia. Laboratory findings: hemoglobin of 9, reticulocyte count of 8%. Which of the following diagnoses would you not expect? 1. Iron deficiency anemia. 2. Hereditary spherocytosis. 3. Thrombotic thrombocytopenic purpura. 4. Autoimmune hemolytic anemia. So the patient obviously has anemia, hemoglobin of 9. The reticulocyte count is 8%, but we first calculate reticulocyte production index by dividing patient's hemoglobin by a standard hemoglobin, then multiply by reticulocyte count. That results near 4%. That means it is more than 2%, so we should expect an anemia with high reticulocyte count. Iron deficiency anemia is obviously a hypoproliferative anemia with microcytosis, hypochromia, and a low reticulocyte count. So the correct answer is option 1. In other options of this question, we expect hemolysis that will be discussed individually in a separate video. Question 7. A man presents with fatigue and lethargy. On physical examination, the vital signs are stable, but the conjunctiva is pale. The laboratory tests are as below. White B cells 8,000, hemoglobin 6, hematocrit 20%, MCV 90, and reticulocyte count 4%. Platelet 250,000, LDH 320. Which of the following diagnoses is most likely? 1. Chronic kidney disease. 2. Acute hemorrhage. 3. Intravascular hemolysis. 4. Extravascular hemolysis. Fatigue, lethargy, and pale conjunctiva are clinical manifestations of anemia. According to lab test, hemoglobin of 6 reveals anemia. MCV is 90, that means normocytic. So, in this category, reticulocyte count should be considered, that is 4%. That apparently is more than 2%, so the options 2, 3, and 4 are probable. But this assumption is not correct. We should calculate reticulocyte production index by dividing 6 as patient's hemoglobin by 15 as a standard hemoglobin for men. As you know, a standard hemoglobin in men is between 14 and 16, and then multiply this fraction by reticulocyte count. So the result is less than 2%. That means conversely, the options 2, 3, and 4 could not be the answer. Actually, in this question, anemia of chronic disease such as option 1, chronic kidney disease, could be probable. What we can conclude from this question is that anemia of chronic disease could be with low or normal MCV, but the reticulocyte count is lower than 2%. Question 8. Using which of the following medication is compatible with these laboratory findings? Hemoglobin of 9 and MCV of 110. 1. Methotrexate, 2. Penicillin, 3. Warfarin, 4. Levothyroxine. In this question, what we see is a low hemoglobin and a high MCV. In fact, here we have macrocytic anemia. Macrocytic anemia itself could be divided into two groups, megaloblastic and non-megaloblastic anemia according to blood film. Megaloblasts actually are large immature red blood cells. Another finding in the group of megaloblastic macrocytic anemia is hypersegmented neutrophils. What can cause megaloblastic macrocytic anemia include vitamin B12 deficiency, folate deficiency, and drug toxicities that impair these molecules such as methotrexate. In the category of non-megaloblastic macrocytic anemia, we only see red blood cells that are large and mature. This group includes alcoholism, hypothyroidism, liver disease, pregnancy, and myelodysplastic syndrome. So the correct answer is option 1. Other drugs except methotrexate that can cause megaloblastic macrocytic anemia include phenytoin, barbiturates, and primetamine. Question 9. In which of the following patients the corrected reticulocyte count is much lesser than the others? 1. A patient with G6PD attack. 2. a patient with gastrointestinal bleeding 3, a patient with hemolytic uremic syndrome 4, a patient with vitamin B12 deficiency. We talked about the groups of anemia with increased reticulocyte count that includes hemorrhage and hemolysis. Hemorrhage as option 2 and hemolysis as option 1 and 3. So in B12 deficiency, we don't expect increased reticulocyte count. The correct answer is option 4. Question 10. A 30-year-old woman presents with irregular menstrual cycles with severe blood loss. The patient has received oral iron supplements for 3 months. Here are the laboratory tests before and after this prescription. Hemoglobin before treatment 8.5 and after treatment 10.5. MCV before treatment 76 and after treatment 98. Ferritin before treatment 5 and after treatment 35. And platelet count before treatment 480,000 and after treatment 390,000. Despite receiving this treatment, the woman complains from fatigue and lethargy. The blood film also reveals no abnormal finding and reticulocyte count is 1%. Which evaluation is more appropriate in this case? 1 TSH measurement, 2 folate measurement, 3 bone marrow biopsy, 4 direct Combs test. In the history, irregular menstrual cycle and blood loss implies iron deficiency anemia following irregular menstrual cycle. That a hemoglobin of 8.5 and a decreased MCV are compatible with diagnosis. If you look at pre-treatment test, you notice a high platelet level. Actually, in iron deficiency anemia, we have thrombocytosis. However, after 3 months of treatment, the patient is still anemic, but with a MCV in the upper limit of normal range. What do you think about a cause behind the menstrual finding, anemia, and partial correction despite taking iron supplements? Actually, this patient has both microcytic and macrocytic anemia that causes low MCV before treatment and after treatment is still anemic with increased MCV. A good justification for these findings is hypothyroidism that causes on one hand abnormal uterine bleeding resulting in iron deficiency anemia and on the other hand causes macrocytic anemia in the category of non-megaloblastic as you see in the previous question, and the blood film is normal. So the correct option is 1.